Hello, everybody. Welcome to the VIF meeting. This is Gustavo Odrich. I'm in Houston, Texas, at the University of Texas, and today we're going to discuss here with our friends about a very important topic, which is radiation and imaging. We all know that we are more and more going towards endovascular procedures, so radiation is part of our life. We are exposed, our patients are exposed. We also have very complex procedures in the arterial, in the vascular field, in the venous field, and we need to be precise. We need to see what we are doing. So we have a panel of experts here, and I will start with Joe. Why don't you tell us a little bit about your workflow, in terms of the cases you are doing and how it evolved in imaging, and what are the areas you think we still need improvement?
Thanks, Gustavo. It's a great question, and I think it has evolved over the last 10 years in terms of how we responded to a lot of the technologies that have come out. And I think namely is how can we get great image quality and lower the dose and exposure in the operating room? With that question in mind, we had gravitated toward a GE system. And with GE, there are a lot of protocols where you can do some digital subtraction imaging and also taking that radiation dose to a higher level, but rather doing a digital zoom instead of doing an actual zoom. That, along with overlays for complex aneurysm work, has been instrumental in minimizing operative time in addition to cannulating visceral vessels in a more timely fashion and thereby reducing dose as well. In addition to that, there's been a lot of positioning of proper guards within the operating room to minimize dose as well. So I think from that standpoint, GE has really transcended what we had before in terms of reducing our dose. And thus far, there are a lot of things that you're probably going to speak about that have transcended that as well. So I think movement is great in terms of where we're going and reducing dose, but that's how we do it at Cooper.
Thank you, Joe. I would like to say that we are all getting better, but in fact, I'll tell you my own experience is that I didn't get much better or much faster for the last 7 years, and it's amazing the impact that the industry in imaging has had, and in our case, we also use the GE in terms of reducing the dose. I just echo what you said. This feature of the digital zoom, it's something we don't talk much about it, but being able to see without actually magnifying the imaging was one of the biggest achievements to decrease the dose. Sultan, I know you are into artificial intelligence and how that ties into imaging.
It's very important to see what's happening in our current practice, and the artificial intelligence have taken a lot in diagnostics and imaging. And you have a GE, we have a GE, and we were able through this to decrease our radiation by 50%. But can you imagine that I could decrease your imaging radiation exposure by more than 90%? And this is the way that we're trying to apply artificial intelligence and machine learning. And we are gaining some new software from CIDR which allows us to do everything with minimal amount of dye, minimal amount of radiation, but give you the perfect ability to see what you're doing. For the fusion imaging is second to none, far superior than whatever I've seen. But still, we are trying to improve our way. I was category B for radiation protection, and over the past 5 years, I've been upgraded to category A. I said, oh God, I'll have increase in anything. In fact, I have nothing. I have to get a yearly medical because of that. So that's why I was so keen to decrease the amount of radiation. And it's important for all of us. My mentor, Ted Dietrich, you know what happened to him because of radiation. He never believed in protection, but this is what happened. So I don't want to see anybody to have this. So I'm having my whole aim to decrease radiation, and hopefully with this amount of AI, ML, and big data analysis that we're trying to imply, even about the movement, about the setup of your table, about the way you're looking at your patient, about the way even the angulation of the machine on the table and the scattering, all of that, if you decrease this 5, 5, 5, at the end it will add to almost about 50%. And it needs a lot of things, and we are putting these sensors on people inside the theater so that to see who's getting more and what could cause this radiation. But we do a lot of great stuff. You were the pioneer in BVAR and FIVAR in the whole world. but see the amount of radiation that you're taking. If I could tell you that with this minimal amount of adjustment and fine-tuning your practice, I'll decrease that by 90%.
I'll stop glowing at night. So, I mean, you also have Philips and you have Cider, you have GE, so you have the experience of, working in multiple systems. And I have to say it's very exciting to work with Philips and the force, the ability to go completely away of radiation, I think is very exciting as well.
Could see how the urologist and the cardiac surgeon are using robotics. We, as a vascular surgeon, we are far away from it, but with the force and the ability to stay out of the table and do everything remotely, this will allow us to do a lot of stuff and give us more ability to focus on what we're supposed to do. We had no investment over the past 15 years, and in the past 3 years, we had almost tenfold increase in the investment in vascular surgery. This is because of people like yourself talking about what they're doing. So we need people like you to push the wheel much more forward in order to get us what we need. And definitely working with different discipline will give you take something from here, something from there, and then you get exactly what you need.
Thank you, Sultan. Aaron, you are an expert on venous procedures, which are more and more becoming complex with endovenous stenting, and it is different. I can tell you with venography, we have a very rudimentary view. So the ability to tie in intravascular ultrasound and other features. Can you tell us about your practice and how important imaging is on this field?
In venous procedures, imaging is almost the entire case. I'm making my decisions based on imaging in every step, as most of you are. Intravascular ultrasound is more of a mandatory tool in the venous space, and we really rely on it heavily, which also limits our radiation exposure. I use DSA imaging only at the start and the end of my case for a single venogram in both instances. Even my most complex cases I do essentially with all IVUS guidance. So using my IVUS, I'm making sure I'm in the correct place. I'm making sure I actually need to treat this patient. I'm checking respiratory maneuvers. I'm checking my inflow vessels. I'm sizing my stents. I'm placing my stents, all with that technology. So I think we've made pretty good headway, and I think most providers are now using that for their venous cases, as they should.
Evan, I know we talked a lot about imaging and the importance of fixed imaging versus C-arm. Can you tell us a little bit about your practice and where your group is evolving in terms of which direction is going?
We've been in the endovascular space, as you know, back to the time of Dr. Veith for some years, and we've continued to work with mobile C-arms. We have hybrid rooms and planning, but the system that we have chosen has been the Zeem system. And when we went from analog C-arms to the Zeem, we were concerned that maybe it would take us half the way or to a more of a fixed platform, but actually it has really gotten us more to 80-90%. The imaging has been terrific. We've looked at the Therenva system for positioning, and it puts a little more pressure perhaps on the preoperative planning, which we should focus on anyway. But it's been a tremendous advance for us. I'm actually really glad also to hear about everybody's interest in the radiation protection, because when I started as an attending, I wrote a paper I talked to Dr. Veith. I said, listen, we got to put radiation sensors on everybody, including the patients, and let's look at it. And we did that. And the thing was, that paper was 20 years ago, and we look back to 20 years prior, I don't think there was one paper in the vascular literature about radiation exposure. So it's fantastic to see that there are so many papers and so much interest now from the companies and from everybody such as yourselves who've been pioneers in developing the artificial intelligence. And to your point, it's exactly right. If you change time, distance, and angle and pay attention, you can probably reduce 70 to 80% of the exposure.
More and more we are going to outpatient labs, and I think that the portable C-arm is an integral part of what we do that is extremely important. And do you use that as well in the outpatient setting?
We're still doing our outpatients, we're still doing in the hospital, because the investment in our outpatient surgery center, just because of overall volume, we haven't made. But having the mobile C-arms allows us flexibility to go into any room in the OR. We're frequently called for emergencies. Many of those cases require an endovascular solution, so we're able to bring the technology to whatever room it is. We happen to be in an area where we see a lot of dissection patients, so the IVUS integrated with the C-arm technology, which also can go to any room, is a huge help if we're called upon.
Well, we have put together an excellent imaging program on Friday, and I urge for those that are not attending the meeting to actually go online and try to watch those lectures. We're talking about many of the things we discussed today. Also, FORCE, the IOPS, which allows you to use GPS-guided sensors, and there is a lot of actually bench work we are doing with HoloLens and augmented reality to try to see, not in the traditional flat plane view that we are accustomed, but really in a different level. Thank you guys for participating, and it's nice to be back in New York again.